So the results over the last 2 years or so for the top 10% of prescribers, this is obviously associated with the child prescribers and child indicators. So from the second half of 2008 to the first half of 2010, we divided the period into 6-month intervals. Patients who were treated with 2 antipsychotics for more than 60 days declined from 10.8% to 9.3%. So these physicians, of all the patients they treated with antipsychotics in the second half of 2008, 10.8% of all those patients got 2 antipsychotics or more. And 2 years later, the 6-month interval, 9.3%. So that's a modest 13.9% decline. In terms of real numbers, the numbers of patients involved, in the first period, there were 900 children who were getting antipsychotic polypharmacy for more than 60 days. And in the last period, there was 772. So there was a reduction, but not a huge one, even with all of the interventions that we were doing. So I guess not surprisingly, but without exception, every physician that the consultant visited with said they are treating the most problematic, the most severely disturbed children that there is. Discussions with the physician and reviews of the medical records by the consultant indicated there was some truth to that. In fact, these are pretty severely disturbed patients. So question number 1. When a child is receiving an unusual dose or combination of antipsychotic medications, what procedures are in place to determine whether or not they were treated with more usual prescribing in the past and didn't do well? You know, presumably that would be the rationale for being on a complex kind of regimen. I suspect there's lots of holes in those procedures, both in facilities and in practices, because it ain't easy to figure out. I also raise it because there might be a way we can help with that, and we can talk about that. Question number 2 and 3. If an unusual treatment is being used and the child is reasonably stable, are there procedures and timeframes for going back and giving more usual, more evidence-based treatment another try? Since the symptoms are relatively quickly responsive to the medications, but the side effects are kind of, particularly of the second generation antipsychotics, which is 98% of what's prescribed to kids, are sort of slow developing and insidious. It seemed to me like there should be some mechanism for doing that, but I raise that as a question. And then the last is based, as far as I know, there's no research that deals with this question, but I know you all have lots of clinical experience. So based on your own anecdotal experience, are there patient characteristics other than illness severity that are associated with the need for excessively high doses of antipsychotic medications or combinations of antipsychotic medications? It would help us a great deal if there was some consensus on that, because then when we're reviewing these records and such, we can say, well, okay, there's not solid evidence for this, but at least there's some consensus among clinicians that are treating this type of patient that indeed some of them do require consistently unusual prescriptions. So I'm hoping at the end of the day, maybe we'll have some answers to those questions. And, okay, let me turn it over to Noreen.
I'm Noreen Dollard, and I work with what we call the out-of-home care study, and it's actually a series of different evaluation studies that we do related to Medicaid-funded out-of-home mental health programs, which includes, obviously, statewide inpatient psychiatric programs. I'd like to acknowledge our team. Lodi and Mary are here, but also John Ropes, Vicky Hummer, Wen Hong Lee, Frank Reyes, Christopher Adler, and Stephen Rogenbaum. We have a very sort of wide portfolio of studies that we do related to SIP. This year, in addition to analyzing claims data and the monthly data that the SIPs submit to us, which Lodi's going to share with you, we do special studies, and we're looking at family involvement in and the treatment of kids in SIP, because as I'm sure you are more than aware, whereas used to have a high preponderance of kids who are in child welfare in the SIPs, that proportion has dramatically fallen. So we have a lot more biological or families of origin, whether they're relative, biological, who are interacting with, who have kids in residential treatment. So that's a special focus for us this year, which we can direct you to our website where our reports are available. ACA sponsors this, our work, and we're very grateful for it. To give you a little bit of context, SIP is one of 3 out-of-home mental health treatment programs for kids with serious emotional disturbance in Florida. Intensive residential, kids have to be a danger to themselves. Children and adolescents have to be a danger to themselves or others. And really the purpose is to stabilize them and reconnect them with family and community. And this is more for our out-of-state guests. The rest of you know this. Length of stay is currently about 6 months, and we have 15 SIPs at the moment with about 400 beds across the state. We have the new SIP, Baycare, and Dr. Hong is no stranger to us, but he's now with a new facility. And Central Florida Behavioral, which wasn't able to send a representative. The characteristics of kids, demographic characteristics of kids have been very, very stable. We've been doing these analyses since I think 2002, and it's always about 60% male, 40% female, 55% white Caucasian, 27%, 28% African or Caribbean Black, Hispanic about 11%, and then less than 5% Asian Pacific and children of multiracial backgrounds. As has been true, majority are kids in the adolescent age range. The diagnostic patterns have been very, very stable over time. We have 3, the same mood affective disorders, disruptive behavior disorders, attention deficit disorders are consistently in the top 3, not surprisingly. And then it starts to fall off pretty dramatically after that with other diagnostic groups. So I'm going to turn it over to Lodi. She's our incredible data analyst and keeps track of all this for us.
I'll just give mostly a quick overview of some of the trends that we found. When we look at children with mood disorders and we want to know more about co-occurring diagnoses, we found that about 13% of children with mood disorders had a co-occurring diagnosis. These are children who were admitted in 2010. The most common was disruptive behavior disorders. For disruptive behavior disorders, almost 50%, 45 to 50% of those youth had a co-occurring disorder. The most frequent was mood disorders. And for children with ADHD, about 1/3 of them had a co-occurring diagnosis, most commonly disruptive behavior disorders. We also decided to take a look at the physical health diagnoses for children who were admitted last year. We have a really large other catch-all category, unfortunately. But one way to interpret this is to say, we're looking at asthma, for example, 23.1% of all of the diagnoses for physical health diagnoses were for asthma. About 14% were for obesity. Other includes things like vision and hearing related problems, infectious disease, brain injuries. It's really a catch-all. And I also wanted to mention, of all the children who were admitted, about 1/4 had a physical health diagnosis that was listed on the admission form. There might be a lot more kids. We don't really know, but that's the data that came to us. So about 1/4 of them had a physical health diagnosis. So stepping back from diagnoses and looking now at psychotropic medications that were prescribed at admission, overall, about 3/4 of the children who were admitted to SIP in 2010 had existing or prior psychotropic medication prescriptions. On average, each child had about 3 specific prescriptions at admission. It ranged anywhere from 1 to 7. And these are for specific drugs, not necessarily for drug categories, but actually for specific drugs. About 76% of the kids who received a psychotropic medication at admission were prescribed atypical antipsychotics. So that's the really big category there. We also decided to take a look at concurrent psychotropic medications. Roughly 90% of the children who were admitted to SIP were on multiple psychotropic medications. And if you just take a look at the children who were on atypical antipsychotics, about 40% of them were also on stimulants, 37% were also on mood stabilizers, and you can see there were about 12% who were on no concurrent medications. And if we look at the children who were on mood stabilizers, about 78% were also on atypical antipsychotics. For children on stimulants, about 78%. And the same is true if, we can go to the next slide and look at SSRIs, we look at alpha agonists, look at newer antidepressants. About 2/3 to 3/4 of the children were also on atypical antipsychotics. And I think this is sort of very consistent. And then we decided to kind of cross this information and look at specific disorders and to look at the medication categories that were prescribed, or the medications that were prescribed for children with specific disorders. Now, I just wanted to point out that this analysis is restricted to children with mood disorders only. So we didn't look at children with comorbid disorders. These are children only with mood disorders. And atypical antipsychotics were the most common class prescribed for children actually with all disorders, except for ADHD, where you see stimulants more frequently than you see atypical antipsychotics, but they're almost the same. For anxiety disorders, about half were on atypical antipsychotics, and the next slide should be schizophrenia. What you would expect, about 2/3 are on atypical antipsychotics. And then we decided to take a look at diagnoses of youth when they were discharged from SIP in 2010. Now, these are not necessarily the same children who were admitted in 2010. We could have some children here who were admitted in 2009, but I think the overall picture would be the same whether you have the same kids or maybe slightly different kids. At discharge, slightly fewer kids were diagnosed with a mood disorder, but slightly more were diagnosed with anxiety disorders and schizophrenia. As compared to at admission. So if you go back to the admission slide, you'll see how the percentages shift a little bit. And our last slide is a breakdown of psychotropic medications at discharge. 80% of the youth who were discharged in 2010 had mental health medication prescriptions. And this is sort of in contrast to the 73% who had these psychotropic medications prescribed at admission. So slightly more, a slightly higher percentage had medications at discharge. But on the other side of that, each child had fewer medications prescribed. So roughly 3 at admission, 2 at discharge. But the range was the same, anywhere from 1 to 7 medications. And in terms of atypical antipsychotics, the proportions are almost identical. 75% at admission, 76% at admission, 75% at discharge. So that's all.